is The Last Word.
And welcome to yet another edition of The Last Word. On this show, we get to canvass critical issues that are of national importance using data and insights to arrive at truth. Now, tonight on this episode, we focus on Kenya's war against HIV and AIDS. And Kenya has been a global success story in this particular fight. But now the war is fighting back. Recent data from the National Syndemic Diseases Control Council indicate that after years of progress, new HIV infections have tragically spiked by 16% to more than 20,000 new infections as of 2024. Now, commodity shortages are also in short supply, and the 2027 goal is in doubt. We have in studio here tonight among us for this discussion Douglas Bosire, who is the acting CEO at the National Syndemic Diseases Control Council, that will help us to answer the question that we are asking tonight. Is Kenya's war on HIV and AIDS on track? We are also joined by Dr. Andrew Mulwa, who is the head at the National AIDS and STI Control Program, as we converse on this conversation. But we'll be getting to that in just a while. Let me introduce our co-host on The Last Word, as we are here just like this every other Tuesday. On the extreme right, Zaha Indimuli. We have James Smart, and on my left, Eric Latif, and myself, Sharon Momanyi. Many thanks for making time to join us on this show tonight. And as usual, every week before we get to the main discussion of the show, we get to share what has been bugging us for the week, or issues, news, topical matters, that are causing a buzz that we feel we need to speak about. We call it the hot button segment. And tonight we start with Eric. What has been hot for you this week?
Tonight, I want to begin with a rant. And I want to rant at our medics and our authorities, people in positions of power. Now, we have seen over the last couple of years the emergence and the growth and development of the unions in the medical profession, whether it's the Clinical Officers Union, the Medical Professionals and Dentists Union, the Nurses Union, and they have been good at advocating for the welfare of the medics. We've also seen government doing what the government does, engaging with the medics, at some point not honoring the deals that they've signed with the medics, and then medics go on strike, and the government goes to court so that the strike can be declared illegal, and so on and so forth, and the back and forth. In all of these, we always have a patient who is affected. When medics down their tools and they don't go to work, when counties don't pay the doctors, when the government does not absorb the UHC workers and all, it's patients who suffer. Now, recently, we've seen this sort of very, very ugly spat between the medics unions and the county government of Kiambu over deaths in Kiambu, various facilities, particularly the Kiambu Level 5 and Thika Level 4, and its infant deaths as a result of a strike that's been there for 4 months. The doctors' unions came and told us that over 130 infants had died in the last 4 months in these two facilities alone. The county government of Kiambu came and said, no, this number is inflated. This cannot be the truth. This does not go with any data that shows, the kind of admission that we've seen in these facilities. And the back and forth has been on the number, with doctors saying this, the county government saying the other. A number to them could just be a number, but it is people. And in this particular case, it's infants. And what's really pained people is the fact that somebody has gone to hospital to be delivered of a baby, they get a baby, and the baby dies in the hands of medical professionals trained in this country, registered and licensed in this country, and working in a facility, a public facility. And the back and forth is, no, they are 130. No, they are not 130. No, they are 18 this month. No, they are not 18. There could be 11. And I'm saying, we've got to stop that. I mean, it's got to end. You have to stop using patients as bargaining chips for your tough wars or for your push for your welfare. It doesn't really matter. The fact that doctors could come out and just say, throw a number, and we have to get into an argument about the number, it's very insensitive, what I feel. Yeah.
Right. I could see the heaviness of how this landed on you.
Yeah. As a person in the same field, I'm like, it's usually constantly a political battle. And one of the few things you remind yourself in the oath is that patients are never your bargaining chip, just like Eric is saying. Well, I'm not very far from ranting. I'm with Eric in ranting there. But my hot button of the day is a deep moral rotting behind the pulpit. And I know it might look as if I want to give this individual a platform, but my hot button today is Pastor Nganga. And we have seen the end femicide movement happening. We've seen cases of GBV happening. We've seen Nairobi Women's Hospital saying they're receiving 4,000 cases on GBV monthly, totaling to around 48,000 women reporting to one hospital on matters GBV. Yet you have a pulpit that speaks very proudly of how they raped a woman, with seven extra men. 8 men raped a woman, including Pastor Nganga, and left her for dead. But before I put words in his mouth, let's just listen to what Pastor Nganga had to say in his service.
Mwanamke moja, wanaume 8, Tamagui. 8. Sasa tunajuaje na tulimwacha hapo?
Na si hatujui tulimwacha hapo. Those words got me so angry because I was present during the Kware massacre follow-up on last year. And we saw what had happened to those women. We've seen sexual violence happening in this country. Pedophilia is in Kenya. Sexual assault is in Kenya. Femicide is in Kenya. Yet you dare on a Sunday service utter in the most barbaric ways that you raped a woman with 7 others and you left her for dead because you didn't care as much. Why is he still free? Why is he still standing in front of a crowd? What is the DCI? What is the police doing? What is the Gender Commission doing? What is NGEK doing? It's so exhausting to exist as a woman in this country and then to have the church be complicit with such mediocrity. For me, he's not even my hot button, he's my rage button. He's my volcanic button today. Because it's barbaric, it's a shaming, it's a public confession without accountability. It's religious spaces hosting patriarchal prowess that allows women to be humiliated and their deaths to be seen as nothing. And yet the guy is still free. To all the people who go to that church, start praying for yourself. You do not need that. That is my own button for today. My name is Zaha Ndimuli.
Right. I mean, I think we all watched that with jaws dropping.
It's ridiculous.
It's ridiculous that people who hold such important positions, you know, they speak to so many people and have this kind of influence to be so careless with such sensitive remarks. Yeah.
Absolutely. I think one of the issues, I think as society as a whole, we have to ask certain questions about people who we hold to have positions of influence in our society, and why they are where they are, and the responsibility of all of us to platform them. So it's a responsibility for all of us. I suppose those, everyone watching should be asking those questions that Zai is asking. What happens to the institutions that are supposed to investigate and hold people responsible, but all of us to really look at how we platform people that we think should hold positions of authority in our society.
Right. You know, it's also interesting because this is the same guy who slapped somebody in his church for sleeping. Like, didn't we get the red flags, guys?
Right. Okay. We have to get to the main topic for the day. And remember, the question we are asking tonight is Kenya on track in its fight against HIV and AIDS? And of course, this is coming off of recent data shared by the National Syndemic and Diseases Control Council. And we just want to start, maybe just start with you, Mr. Bosire, to give us a real picture of what the data indicates and the position then that it gives in terms of all the efforts that Kenya has been putting in all these years. And of course, we've seen the progress. We got to a point where, we had really gone above the UN AIDS triple targets of, the people living with AIDS, knowing their status, being on HIV, living with HIV, knowing their status, being on the drugs, and reducing the viral load. How are we doing?
Thank you very much for the opportunity. And first, from the onset, I want to thank NTV for inviting us this evening to share on this very important and contemporary issue. If you look back over the last 2 decades, you will realize that the country has made tremendous progress towards the response, in the response towards ending HIV and AIDS as a public health threat. Over the last 2 decades alone, we have reduced the number of new HIV infections from 94,000 to 19,991 in the year 2024. Over the same period, we have reduced the number of AIDS-related deaths from 110,000 to about 21,000, which is about a reduction of about 81%. Over the same period again, we have reduced mother-to-child transmission of the HIV virus from 35% to 9.3% in the year 2024. So the answer is a solid yes. We are making progress. We have made significant steps. However, when you granulate the data and you look deeply and ask yourself, is there any cohort of the population where we are not doing well? We realize that there are areas that are, holding us back. One of the areas that is holding us back is keeping our children on treatment and ensuring that they are virally suppressed. Children are being left behind, and mother-to-child transmission, where we are hoping to eliminate by having it less than 5%, is at 9.3%. The other cohort that we have seen...
Just a clarification, when we say children are not on medication, these are children who have already been tested and found to be HIV positive, but are not then on medication.
It's children between 0 and 14 years. When we look at our cascade of 95, 95, 95, it means that we are supposed to identify 95% of the people living with the virus. We are supposed to identify those people whom we have identified and are living with the virus. 95% of them should be put on treatment, and 95% of them should be virally suppressed. The most important is the viral suppression part. Now, when in the ordinary population, the viral suppression among adults is about 79%. In children aged between 0 to 14 years, we realize it's about 66%. Therefore, the children are generally left behind because the virus levels are not controlled, and they end up developing the full-blown HIV, advanced HIV disease. Now, when you look at the cohorts, the population cohorts that contributed most to the 19,991 cases of last year, you realize that 41% of them were adolescents and young people aged between 15 and 24. 41%. If you expand that bracket to 34, that means 15 to 34, 75% rather, of all the new HIV infections that occurred in 15 years and above occurred among that cohort. 75% aged between 15 and 34. What does that tell us? That tells us that is the group that we need to look at. That is where we need to make intervention. We need to make intervention in making sure that the mothers who come for, all the mothers come for ANC services at our facility. Because when they come for antenatal care, then they are tested for the virus, and if they have the virus, they are put on treatment. That is the surest way of ensuring they don't transmit the virus between them who are positive to their children. 2/3 of the mother-to-child transmission cases that we have, and last year we had about 3,600 infections between mothers to, in children, about 3,600. So 2/3 of those infections are as a result of mothers who are pregnant, not being on treatment. That means not being initiated on ARVs.
Right.
In most cases, they never even knew their status.
Right.
Number two,
yeah.
mothers who are interrupting treatment, 2/3 of those infections. So we can actually address, if we address those two components, mother-to-child transmission and these infections among adolescents and young people, which threaten also the social, cultural, and economic development of the country, then we will go a long way towards addressing these teething issues that we are noticing.
Right.
But however, remember,
we'll come back, yes, because I think we'll deal with the demographical, challenges particularly, because there are different challenges that face these new infections amongst different demographics. And I just want to bring in Dr. Andrew Mulwa, who's from the National AIDS and STI Control program, just to speak on the same. And Bosire has highlighted these two particular groups of people, the transmission from mother to child and amongst adolescents. Do you find this to be the biggest burden, demographically, when we are dealing with the control and managing new infections?
Thank you very much. Again, like my colleague, I'll begin by thanking NTV for giving us an opportunity to have discussions with the citizens of this republic on this pertinent issue. I think Dr. Bosire has highlighted the progress that has been made over time. And we must also, as a country, appreciate that we have made progress in terms of HIV to the extent that we are near universal coverage of HIV services, where when you look at the statistics from the previous estimates for last year, we were doing 98%, 98, 97, 94%. Of course, mentioning the three subpopulations that we feel that have not been properly addressed. The pediatric age group, the adolescent young people, and of course, breastfeeding and expectant management of HIV. Those are the three cohorts that we feel have gaps. Of course, we have, over time, studied the epidemic. We know certain subpopulations that transmit. For example, female sex workers have a 27% HIV prevalence rate. People who inject drugs, about 12%. Men who have sex with men, about 18% of HIV prevalence. This is against the national prevalence of HIV of about 3.3%. What does that mean? For the 30, 40 years that we have been working in the HIV space, we now understand the virus. We know how it is transmitted. We know who is transmitting. And some of the statistics that are coming from these estimates are actually pointing at that we can focus our interventions on these areas that we feel performance is not working well. And that is where, as a program, we are focusing our efforts in adolescent, pediatric, and in the key populations, the populations that I've talked about that have a higher than normal prevalence of HIV, which means if we don't close the tap, new infections will move from these subpopulations to the rest of the population. I think for us as a program and as a country, we can pride that and these statistics, for the record, are statistics for the period ending December 2024. At the time, so that it's clear, we did not have the global health disruptions that have occurred in the year 2025. The 2025 estimates will probably give us a picture of what the withdrawal of funding and all the stop to work orders, the effect of that. That we'll probably know in the next year's estimate, so that it's clear these are statistics that are coming at a stable programming situation, where we have ARVs, we have programs from USAID, PEPFAR, all across the country, no disruption, because we may easily start pointing fingers and say, this is a result of disruption, this has nothing to do with that. These are statistics as at December 2024, before any stop to work orders or disruptions happen. So I think we have to put this into perspective and recognize that, one, with continuous use, I think the oldest patients who received free ARVs are doing their 20 to 25th year of life. Those who began the HIV program in free ARVs. There is what is called drug lethargy. That someone feels, I've taken these drugs, I've been virally suppressed, I am leading a near normal life, and they start getting tired. These are some of the things that are contributing, and we have started seeing this trend from as early as 2021. We have seen re-emergence of what we used to call advanced HIV disease. Because people are getting tired of taking drugs. People are living longer with HIV, and that therefore means they start feeling like, can I stop, can I take a break, and because they feel like they have led a normal. And these are some of the things that we have as a program to continue addressing on a day-to-day basis. Right. So from where I sit, I am not worried about the statistics, because that is what surveillance is about. Is about to point where issues are going south, so that corrective action can be taken before things get out of hand.
Right. And we'll get more to that. The audience will be getting your questions and comments in just a bit. But I'm wondering, do we need to reintroduce with a lot of intention the kind of awareness programs that we had earlier before? Because, as Dr. Mulo is saying, is evidently a bit of a relaxed stance as comes to, HIV in the moment. We've seen even people saying they're more scared of, getting pregnant than getting infected. So is this a win? Because does this show that we are moving away from stigma, the stigma that we were fighting from before, or are we now going to the other side of the pendulum? I don't know. What do you think?
I think it's a mixture. And as a Gen Z in the room with your statistics really attacking us here, I think there's a very key difference between how campaigns around HIV and AIDS were done way earlier and what we're seeing right now. I think maybe I'd love to get into detail of how those campaigns and education and awareness are being done with people in that age, because I came across a statistics as well within your report, and it's the AIDS-related deaths between the children between 0 to 8, which is 910 for males, 887 for females. And because I saw you giving out the data, I'd want to get into a glimpse of, are we actually having an accelerated number of children dying due to advanced HIV? And if that is so, where is the transmission coming from? Because again, these are toddlers, if I may say. But with the adolescents that we're having, and it's good for us to correlate the socioeconomic input of most of these situations, especially with the new infections. Has Kenya addressed sex for pads, for example, in Lake Victoria region? Have we addressed the concerns between the COVID period and the transition that Kenyans had from being locked down to outside here? Are these transmissions, these new infections coming out from also a socioeconomic problem? And I think something we were also raising when we were having this discussion, there was a how do you call this, a protest by members of NEFAC the other day in October, talking about stigma, institutionalized stigma and discrimination with their access to healthcare. So with Kenya making so many strides and the limitations and problems being very little, are we also in a situation whereby our institutions are also too comfortable, that we have done so much progress that we're not picking up on these issues? And if I am wrong, I'd love to learn, then what are these gaps, and then how does correlating and working together now bring a solution that's more impactful?
Right.
I think it's important to sort of put all these things to live in a certain context. And for me, I think the question that we should exercise our mind on is why these infections are happening to the group that is happening to the 15 to 34-year-olds. And I get the sense that the fight against HIV and AIDS, those 30 years ago, was moralized. And we attacked it as a disease that was killing people who were immoral. And those who are fine shouldn't have been, being affected with this disease. And that really lifts a scar in our communities, to the extent that by the time we were realizing that this disease is going to wipe out, all of us, the moral debate of where this is happening, it was in families, it was in homes, it was everyone. And that stigma really never left us. And it leaves us in this position whereby we are unable to speak about HIV and AIDS and the stigma that is involved in a way that is inviting all of us to have a conversation about our society. Because these new infections are not happening without a context, all right? Yeah. The 15 to 34-year-olds are not getting infected a bit more because they are sequestered out somewhere in the society. They live in our society, and our inability as a country to open up the veil and the conversation and discuss the issues of how the society is set up, whether it is a cultural issue, whether it is an economic issue, whether it is how we relate with each other, how families are relating, is getting in the way on how we completely have the same level of information so that we are able to empower all of us. I'll give a final example. It's impossible outside today to discuss sex education in any context, all right? It becomes political. It becomes a moral debate on an issue of as simply as, do we want to let all of us know, and our children and everyone else know, what is sex behavior, what is safe sex behavior? It becomes a deeply moral, impossible conversation to have. And then it doesn't give any of us a chance to really deal with the important question on how we relate and where the infection is actually coming from. And I think this is where, at the core of our problem, it's a governance question, it's a leadership question, and we can discuss the statistics as much as we'd like, but it doesn't help us to really go to the core of the problem.
It doesn't move us from there. As we're having this conversation, I think let's do two things. Let's poll our audience and find out what they think. And then the second bit is I'd like to find out the average age of the people in our audience. So first of all, you have got the voting cards. For green being yes and red being no, answer the question, is Kenya's war on HIV on track? Is Kenya's war on HIV on track? Yes, green, no, red. Looks like it's evenly balanced. There are those that feel that it's not on track and those that feel that it's on track. Lift it higher so that we can see. Be bold, be fearless. All right. Now, with that, how many in this room and have a card are aged below 34 years?
Aged below?
Below 34.
Below 34.
Majority.
All right.
Okay, not all of us.
Okay. So, going back to the statistics that Dr. Basira was giving us, we're seeing more and more infections in this age bracket, right, of the below 34s. But remember, our median age as a country is actually this bracket, age bracket.
That's true.
These are the majority.
Yeah.
But there's something that is of concern that Dr. Basira raises, the high rate of the mother-to-child transmission. And remember, the mothers are within this bracket of 34 to kind of 45, new mothers. These are people who have grown up with the knowledge and information about HIV and transmission. And if we again look, and Dr. Muller has even worked in the counties and the national level, will tell us, people are now going to health facilities for antenatal care. So people are actually interacting with medics in the journey of pregnancy. So they have access to information about this, about their status, and about the chances of reducing the mother-to-child transmission if they do things right. But we are still seeing mother-to-child transmission on the rise. I mean, not on the rise, but high. 9%. It should be what? 4%? Dr. Busita, you said?
5.
less than 5%. It's at 9 and above. Then look at these new infections, and if we say that among this age bracket of 15 to 34, we have over 70%, 74%, you said, then there's a question here. These are people who've grown up in this age and era where there's information around HIV, whether in school, at home, on social media, in all the places where you're getting all the other information, including about sex. Yeah. But what is it that even the National Syndemic Disease Control Council was raising concern about? People's concern with unsafe sex is not unsafe sex because of STIs and HIV. It is unsafe sex because of pregnancy. Yeah. Right? The young people in the room? Yeah.
The economy does not allow.
So it's the bigger fear is not the HIV. The bigger fear is the pregnancy and how that disrupts your life going forward. Yeah. Now that comes back to the question. These 30 years, what have we been doing then? If the conversation does, maybe we did too well with the conversation that HIV is not a killer, that you can live. So the HIV now becomes like malaria. Nikipata malaria naenda hospitali napewa dawa narudi nyumbani napona. I have a high chance of recovering, of living with HIV. I don't have an issue. So we dealt with the stigma very well and successfully that it actually went to the other side.
We have deterred fear of infection.
Yes.
Yeah.
I agree and disagree. I think in two ways, right? That I think the information that was there in the beginning, the Rafael Tuju documentaries were really guilt-tripping the young people into, sex, not having sex, all right? And it worked because it was the only thing that everyone watched. It was emaciated people, it was people getting gonorrhea and STIs. They were like really gory images for anyone who knew about this. Please go and look it up. It really reinforced a habit, that I don't want to be like that. So in one level, maybe that worked. But I think what really actually worked was just not the information, the communication, was a deep grassroots community health volunteers in communities who actually went home to home and provided medication, made sure that people are known to be where they were. And these were in rural, urban, poor communities. I'll give an example of Korogosho, for instance, where a group of 18 women worked for almost 20 years to identify each and every home and every person to go and get tested so that they can provide ARVs. And I think that is where, as a society, we dropped it. That this is hard work. It is organizing. It is governance. It is making sure that people can be found where they are from their homes and have the safety to be told or to feel seen that, yes, I can go to be tested, I can get medication, and then I can be fine. I think we dropped that to something else, which is this massive public show of delivery without the actual work that is happening in the community. And I think that's where we dropped the ball.
I really agree with James, because it's like the way the Western countries make Africa look like we're still in a jungle, and the only pictures you get are people in huts. And just on that point, I think we really made and constructed the narrative around HIV and AIDS as this gory, like you said, bad thing you're not supposed to see, and belittled people with living with HIV. And also I think this is also a very systemic way of abuse, one way or another, because again, it tends to dehumanize people living with HIV, and there are so many variations of how these infections happen. So you have enacted stigma, anticipated stigma, internalized stigma, and these forms of discrimination are very expensive to these people living. We've seen cases roaming around of people infecting others due to revenge. We have seen people not being able to have resources to actually get into this process. And I think also disclosure issues, because again, we're in a society that's not very accepting and not very kind. When you speak about your HIV status, the first thing is, no, oh, we have you, we have your support, you have my support. No, the first thing is stay away from me. And we put our siblings living with HIV every single day in a cocoon, just like the way back then.
No.
Really?
Oh my goodness. 30 years ago?
It was worse.
Horrible.
Yeah.
30 years ago, and that's why the many programs that were implemented by government were specifically addressing the stigma. Yeah. In fact, the initial messaging on billboards and all was AIDS kills. And that had to stop. That had to stop over 15 years ago, right? It's changed.
I think I would say we are victims of our own success. We have done so well that what used to be a problem has now stopped being a problem.
Yeah.
Prior to 2000, not even 2000, as late as 2005, this Nairobi was full of billboards. HIV, AIDS kills.
AIDS kills. I was doing radio programming. AIDS kills.
And
the deep voice.
I'll tell you, and all of us are as guilty as charged. From the program, from the science, we move from now the health education. Every 30 minutes, you would open any radio station, any TV, there would be a message on HIV.
Yeah.
But we made progress.
Yeah,
we were making a lot of progress, so we scaled down on the messaging, education. But the question that we need to ask is, with the new developing platforms for education, what can we change? And that's what, as a program, we are working on. What can we change so that we reach the younger generations with similar messages, not the threatening message of AIDS kills, on HIV, that now can be tailored to address them in the platforms that they listen.
Yep.
I was even challenging some of the young people that we engage with that I have never been in TikTok myself.
Why?
I am in that other generation. So we need to engage young people. Where are we passing our messages?
Yep.
Because if we continue with our good guidelines, with our good posters that we have on HIV, we will not succeed. I grew up every Friday while I was in primary school, 12 p.m., we would have someone come to talk to everyone from class 4 to class 8 on HIV, between 12 to 12:35. It was HIV as a lesson for all classes from class 4 to class 8. Is the same message getting to our young kids?
It's not anymore.
All right. All right. We have a fantastic conversation, and I want us to continue.
Yeah.
But not to be victims of our own success, we have to take a short break. Because when we come back, we'll get to this point, but also talk about how then inclusive we can all move this conversation forward.
Yeah.
What do we need to do? Hang on to that thought. What do we need to do for us to dial up? All right, you're watching The Last Word. We're taking a very short break. We'll be right back. Don't go too far. Welcome back. You're watching The Last Word, coming to you live here on NTV. And tonight we're asking, is Kenya on the right track in the fight against HIV and AIDS? You can have your feedback online through our social media platforms. And of course, we're here in studio and we have been mulling over this issue, the question of what exactly do we need to do as a society to sort of move the needle on this fight against HIV and AIDS, because it affects all of us, right? Infected or affected. On whatever it is of the spectrum you are, it affects all of us, and we need to figure out how to do this together. Before I took the break, and including the audience, Dr. you had a point to make. If you can make it in a minute or less so that we can include everyone in this fight, starting here.
Indeed, this fight needs everyone, James, and you're right. Evidence to what Eric had alluded to earlier. In the year 2024, the country recorded 240,000 pregnancy cases occurring among its children and young people aged between 10 and 19. That's an average of about 660 per day. What that tells you is that there's a lot of unprotected sex that's taking place. Right. And this is among its young people who have never seen somebody living with what we call advanced HIV disease. What you alluded to again earlier, that those of us who were there in the 1990s, when there was no treatment program that was funded by the government for ARVs, which maintain and keep healthy a person living with HIV. The images that James, you referred to, those scary images when you went to a restaurant and if somebody was predisposed to be of a slim frame and maybe that day they had a cold, they're coughing, you avoided that restaurant and actually moved to the next.
Right.
Remember the uncertainties that came even with COVID, lack of knowledge, lack of science. That is where we were. However, the young people who were born after the 2000s, I've never seen those cases. So for them, because people are on treatment, and anyone living with HIV looks like you, looks like me, you cannot tell. So you can't tell it from the face until you are tested. So sometimes these optics also mislead and people are not able to integrate. Number two, the resources that we had back in the day for sensitization and large-scale public education were largely donor-funded. The last grant we had was a total war against AIDS. That's why you had huge billboards, which we cannot sustain now as a nation. That is why we as a Ministry of Health, NSTCC, NASCOP, the county governments, the State Department for Gender, the State Department for Planning have come together with a program called End the Triple Threat of new HIV infections, adolescent pregnancies, and sexual and gender-based violence among adolescents and young people, because there's a direct nexus. If you look at the counties where we're having big circles of new HIV infections among these AYPs, young people, those are the counties that also we have sexual and gender-based violence in high numbers and adolescent pregnancies. So there's a direct correlation. So these are an initiative that is all of government,
something for us to think about.
Yes, that we are working on, and it's bearing fruit. If you look at your statistics, for example, for adolescent pregnancies, in 2019 we had almost 396,000 adolescent pregnancies. Last year we had 240,000. We are not proud, but we're making progress. The HIV cases, the new HIV cases among these people, 10 to 19, were 5,123 in 2021. Last year, there were 2,799, 45% reduction. We are making progress, but we are not at a point where we can confuse progress with success.
Thank you.
And I think that's why we're having this discussion.
Thank you, Dr. I want to include young people in the audience. Let's move the mic. You want to speak? So let's, the lady, you want to speak? Yes. And then move the mic that way, then we'll come there. Right. Please introduce yourself, your name, and what is your contribution tonight. What should we take home? What exactly should we do?
My name is Doreen Moracha. I'm a HIV and AIDS advocate and a social media content creator on matters HIV and SRH. I am very shocked to hear that we don't have stigma, because we still do have stigma. In as much as the stigma index report says that stigma has gone down, yes, it has gone down on paper, but when you open your social media comments, because I publicly live with HIV, I see, especially when the stop work order started this year, I saw on my comment section people saying we are finally going to see how people living with HIV look like. But how do we look like? It's because they want that picture of emaciated people who are about to die. So part of the reason why we still have new HIV infections, especially from mother to child, is because of the stigma. The mothers sometimes are afraid. If I walk into the facility, I get tested for HIV today, I am going home a HIV positive person, and that means I also have the responsibility of ensuring that I give birth to a HIV negative child, which is heavy. There is a lot that goes on in motherhood. So we have not even looked at the psychosocial support aspect for women living with HIV who are of childbearing age. We speak about the numbers, and there's something you raised that was very nice, that we moralized HIV so much, that when I say I'm HIV positive, the first question I'm asked is, how did you get it? The minute I say I was born with HIV, they're like, oh, sorry. But if I say that I sexually got HIV, then that is a whole discussion. So as we sit here and as we discuss the numbers, those are not just numbers, those are people. And we need to ensure that lesser people are getting HIV. I was in Botswana last week, and they are on 0 mother-to-child transmissions of HIV. Why can't Kenya reach 0?
All right. That's the contribution. The gentleman here, there's the microphone to the gent. Yes, please.
My name is Hendrik Omonde Isaiah. I'm a law student, also chair of Nyawaka Social Justice Center. Finally, we are also under the NEFAC membership. We're also under the NEFAC. And for me, most of the time, I spend a lot of my times in ward clinics and sub-county clinics. and lots of proposal rooms when I have the time to. And there was a time we had ODSS training, and I was assisting the elder generation with a few of the programs. And when I said that, oh, it's getting a little bit too hectic, you guys should organize for a technical support, they told me, young man, you don't understand the fight we have been through. It is like we have no right to also feel the stigma, because the people before us felt the stigma more than we felt it, even if it does exist. But that is not what I wanted to talk about. What I really wanted to talk about was, as Eric said, as Smart said, back then we had the CHVs, right? And recently the government talked about a lot of tidy paperwork about, oh, CHVs are going to be turned into CHPs, and they're going to get stipends, and they're going to get accredited, and they're going to get all this. But if you look in reality, if you look at the sense of what is really happening in the ground, most of those things, the accreditation, the payment, even some counties are cut off their financial systems on the CHP's payment and all that. And the CHPs are the real people that really used to treat people, used to give people the education on HIV and AIDS, used to ensure that people stick to their ARTs and the PrEPs and all that, right? The CHPs are what really matter, but with this system right now, they're not really regarded as such. Also, right now I'm sure there's a funding that is coming into place, PEPFAR, and the NSDCC PEPFAR funding. I think it is coming into place, dealing with the TB, dealing with the HIV and AIDS, and dealing with the digital health systems. I think it will be approved by tomorrow to support the government, our government, to deal with these situations, but it is not even really being talked about. We are really wondering, what are the systems, how are they going to handle this? Okay. Because we have gotten to a place where we are funding programs while we really need durable systems. We need to change the plumbing of the whole house.
All right, change the planning, yes. Quickly, so that I can take many comments. Very quickly, what is your name? What is your contribution tonight?
Okay, my name is Ibrahim Achera, and here is my concern. The reason to why we have a large number of youths living with HIV and AIDS, you see, a lot of us, we are being faced with financial constraints. And now, most of us want to actually sort the bills. And in the moment of sorting those bills, it's not that easy. That's why most of girls end up maybe engaging themselves in some bad activities so that they can at least have some money to sort their bills. And you see, we are living in a country where it's not that easy to get a support. Let's assume I am a lady and I want to be given a work. Of course, I have to obey what that person who is giving me work has said. And most of them do tend to misuse those ladies, harassing them sexually. Okay. And you can see, let's say in campus, those lecturers sometimes tend to actually misuse those ladies so that they can give them good grades. And just imagine, kila mwaka kuna freshers wanaingia, and those lecturers want to have at least some freshers, at least one fresher. Now, most of them were infected. How many people do they infect? Kuanzia time walianza kazi to the time they are going to finish those works.
Okay.
Yeah.
Okay. Point taken. It's economic. Yes, please.
Good evening, everyone. I'm Ashley Tinkoi, a student pharmacist at Kenyatta University. So the first question was, at what place is Kenya in regards to HIV? Okay, there's this article I was reading from the USAID. It was saying like there are 9 countries selected for like early 2026. The new ARVs, the antiretroviral therapy, instead of like the TLDs that were initially used, we will have lenacapavir and NRTI that will be taken twice in a year. That means after every 6 months. And Kenya is one of the 9 countries that were there. I hope that's actual and real.
Yeah, finish. We'll come to you. Yes. Yeah, just make your point with the CCI, NRT, DCI.
Yeah,
They
my bad.
make a lot of sense. But go ahead.
Also, okay, the most affected brackets, we have the infants from 0 to 8 years, and we have like the youths. Okay, the infants, we can by infant prophylaxis and safety, like safe baths and use of the ARVs by the parents, we can reduce the number of contractions of HIV to the infants. And also, okay, gender-based violence. I'm also as angry as Zena was, like from the Pastanganga thing. But, okay, if, let's say if, like they were saying, the 7 men who, or 8 who raped that woman, let's say one of them had HIV and AIDS, a higher percentage is that 8 of them contracted HIV and AIDS. These people have their wives, they have their husbands and everything. They keep on contracting them. Can we just cancel GBV?
Okay.
Yeah,
All right. Thanks. She wanted to have a direct response. Yeah. So just bring the microphone and then it's going to get back to the lady. What was your response to her comment?
My response to her was about lenacapavir. Lenacapavir is HIV prevention.
Right.
It is injectable PrEP. It is not for HIV positive people. It is specifically for HIV negative people. I want to speak about U equals U because I keep hearing people infecting. Science says that people living with HIV with an undetectable viral load cannot pass HIV on to HIV negative people. So who is causing the new HIV acquisitions? It's people who are not on treatment, it's people who don't know their HIV status, it's people who start treatment and stop them, and it is people who basically are yet to get tested. But people who have been on treatment for a long time, they have undetectable viral loads, they're not responsible for the new HIV infections. Let us please remove that.
That's a very good... Yes, let's pack the microphone back to the lady. Okay. Yes,
so,
she had a comment before you first. Let her speak first.
Good evening. My name is Doris Kathia. I work with an organization called Raise Your Voice, which is a community-based organization working with sex workers and queer persons and people living with HIV as well as young teen mothers. And my contribution is, James said something about sex education, and that is my contribution tonight. Over the years, we've seen that most of the individuals who call themselves the religious leaders or something, interfaith or whatever they call themselves, they are opposing comprehensive sexuality education for their own reasons. But if we go back even to the conversation that we've been having tonight, we realize that it's because of the education that we got back in those years that has made us to be where we are today, and probably it's what has even enabled the reduction of stigma. And therefore, how about we go back to perhaps having such education in both primary and secondary schools as well as out of school institutions. And we've seen over the years comprehensive sexuality education or sex education or whatever people may want to call it. It's been opposed for several years now. We've continued to fight for it to be put in place and even be added as even a curriculum in schools. But the government, as well the religious leaders, they continue to oppose. Why are they opposing? It's the reason why we continue to have new HIV infections, because people lack education, despite the lack of stock out and whatever it is. But lack of the education is what is also ailing the new infections.
Okay.
Yes, thank you.
Yeah, very good point.
If you don't mind, because you work with sex workers, right? Yes. So in the community, because we've been given the statistics here, the rate of transmission among sex workers, like Dr. you told us, it was about 27%. That's high, right? That's prevalence. It's still high. It's high. It's actually among the highest in this the normal population. So among the sex workers, what is their a level of awareness, and 2, attitude towards HIV and prevention?
Good, very good question. And for the people that we work with and for the people that we've empowered over time, their attitude have obviously improved. It's not like it was before we started the programs with them, because you realize that every other time when you engage people within the communities, they have these intuition that no, that is not allowed, this is allowed, this is not, whatever. Everybody has their own instigation of what should be and should not be, and therefore attitudes of the people that we engage have obviously improved, but it cannot continue to improve if you continue to hinder in terms of how we are sharing information and also education among the people. For us, particularly, just to be clear, we work with young sex workers, and by young sex workers, I mean that those adolescents and young people that Dr. Bosire mentioned that are being, for example, put in that situation by either their parents or even because of the situation at home. So most of them have already been HIV. I've already been living with HIV even before we started the programs with them. But in terms of how they perceive the information that we continue to share with them, it has changed tremendously.
Okay.
Eric, just to support you and to give credit to how important it is to involve key populations, it will be good to bring the attention of the Kenya Sex Worker Alliance.
Yes. And
the fact that since their founding in 2010, the prevalence rate amongst sex workers has reduced from 30–40% all the way down to even 20 in some counties. And it's important that when we're doing our strategic alignment, when we're doing these programs, Kenyan sex workers exist. And their recognition as human beings is equally very important. And therefore, that translates to them being able to deliver messaging and information and advocacy in a more humanized, because most of them are very human-centered and human rights Adventists.
Right.
So it's very
So I was still on the audience. Yes, you had something to say. Please stand up.
Good.
Give us your...
Okay. Good evening, everyone. My name is Masi Wanjiko, and I work with an organization called Ambassador for Youth and Adolescent Productive Health Program. So my comments are just to echo what Dr. Mulwa and Dr. Bosire said. Dr. Mulwa said, in the past we kept on creating awareness. Like we would go to, like when we were growing up, or during their generation when they were growing up, maybe at lunchtime, there used to be like a teacher or someone who came to speak to them about HIV. I think it's high time, not even only the ministry, and even maybe like the TV stations, they don't have to be paid to advertise. They innovatively pass information on HIV that is correct and consistent. We don't want to move towards new HIV infection. We have a basket of HIV prevention tools. Thank you.
All right. The gentleman at the back.
Hi, my name is Max Ugola, and it's an honor to be here. Rather, I'd start this conversation from the very beginning, when the first HIV positive individual was confirmed in Kenya. That was in 1984, and it was actually a Ugandan journalist who was found positive in Kenya. And I've had conversations on stigma from Smart and Eric, which are actually very impactful. The fact that at one point HIV was moralized. So pardon me, I'd start there, then I'll make my point. I feel as much as we are saying stigma has improved over time, we have to see the work that stigma has taken over the nation. And sometimes back, I was working for Ambrose Rachier, who is the chairperson of KELIN, actually an individual who is very, very key on the fight against HIV/AIDS. And he told me, at one point, stigma was so high that even the government officials would not present a paper before the World Health Organization. And the government officials had to contract him as one of the individuals who are very evident as ambassadors in this fight to present a paper before the World Health Organization. So as much as we are talking about stigma, we have to first appreciate that even the government of Kenya is struggling to fight the stigma against fighting HIV/AIDS. Now let's come to the present present day. As much as these experts, and they have had very impactful statements that I have learned from, said that stigma has been improved, there is a concept to it, and this is the concept. The methods of teaching about HIV and AIDS are purely traditional. They are talking about sex, they are talking about blood transfusion, they are talking about sharing of objects and such like things as ways of causing the transfer of HIV and AIDS virus. But we deal with a very modern society, and I like to what the gentleman said about the key population. Myself and this gentleman here, we have been part of Amka Africa, which is actually a very active organization in fight of African health. And something we're being told is that there's this special group called MSMs that I've heard him mention, men who have sex with men and don't identify as gay, who are actually key propagators of this virus. So this is my take. My take would be like, right now in this 21st century, our focus really needs to be on who is really transmitting HIV and AIDS, that's one. And two, how is the government treating the stigma that's associated with HIV and AIDS? So who is actually transmitting HIV and AIDS? The youths have been quoted, and the numbers play very well when you mention them statistically. I like what Zaha said, that the numbers are human beings. So we need to deal with it from that aspect. And I'd say this, as much as the youths are really not afraid between pregnancy and HIV and AIDS, that they'd rather take P2 rather than actually protecting themselves against HIV and AIDS, the fight against HIV and AIDS right now is in our households. And so it requires that we look at these individuals very selectively, because it's either we are infected or we are affected. Right. It's either you have the disease or someone close to you has the disease that impacts you. And as a result, these key populations really need to be the concern of the government. As much as we are fighting against LGBTQ, we are fighting against the positions of people like intersex, we are fighting against MSMs, I feel like the health sector needs to create a platform that all these individuals get access to medical services so that they do not become a threat in the entire society. Because if you have an individual who do not identify as gay and have sex with men and still go back to a wife, you know, that way you create a chain of transmission. Okay. So my take tonight is, let us focus on the population that transmit this disease. Thank you.
Thank you. Thank you for that. Give the microphone to this gentleman. He had raised his, and that gentleman, yes.
Good evening.
Then I'll have have some responses from our experts tonight. Yes.
My name is Nelson Akoth. I work with an organization called Network for Adolescents and Youth of Africa. My comment would go to what Eric had mentioned about information, that young people grew with information. But we understand that there are a lot of information, both misinformation, wrong information, and all these are information. And when James mentioned about sexual health education, I think that is where all the buck stops at. Because if a young person understands that if sex happens, this is how to do it safely, this is how to say yes, this is when to say no, and these are the steps that I need to take. Where do they get that information? Young people trust three people. The first person is a healthcare provider. The second person is a teacher. The third person would be someone in uniform, whether a chief, police officer, or someone in that line. But do we give young people a room to engage with these people and have conversations around sexual health? Do we? That is an area that until we get time to have conversations and give young people a space to have these conversations, then they can verify the information they get on TikTok or Facebook or whichever platform they get the information from. So unless we have that as a way of ensuring that young people have information. And also to add, I think this year, one of the things that government did, and I did say we are on the right track, is the treatment optimization program. I think that is one of key issues that if maintained and government puts a lot of effort onto it, then when it comes to suppression and really ensuring U is equal to U, which I think Mora also mentioned, will help us to minimize and really reduce the rate of infection. I think that is what I had for now.
All right. Let me get these last two comments, then I have some responses from my experts.
Thank you, Eric and the co-hosts. My
Don't
brother.
See us.
Sorry.
We are also part of this thing.
Yes. And the
just
co-host.
can't say Eric. Anyway, go ahead.
Okay, thank you.
Easier to remember.
Go ahead.
Okay. My brother Akoth talked about the people who young people trust. I think he mistakenly failed to add lawyers in that list. Thank you so much, and to the audience who are viewing for staying this late. My name is Odindo Yoga. I am a lawyer with Muma and Kanjama Advocates. I'm pleased to be here today. This is a topic which is crucial to the society and to Kenyans at large. I would like to first comment on an issue on stigma. It has become a heated topic now, even before and after when we were discussing with my friends about this particular topic of today. And in my opinion, there has been a significant decrease in stigma among people living with HIV/AIDS, and thanks to the awareness by the NGOs, the government, and the stakeholders. An example can be pointed out to the recent protest by people living with HIV/AIDS for inclusion in SHA. So what I'm not sure is that were they people living with the HIV/AIDS, or were they activists who are fighting for the rights of people living with HIV/AIDS? That one is...
Would it make a difference if there were people living with HIV/AIDS, if they were activists? What's the material difference?
The material difference would be the stigma part, because stigma will reduce your self-esteem as a person living with HIV/AIDS. And what you'll do is that you'll try to hide. You say, I'm not coming out as a person living with HIV/AIDS.
She's disagreeing.
I see.
Yeah. What exactly is the point? What's the point you're trying to make? That if persons living with HIV and AIDS do not have a public way on how to advocate for themselves.
Yes.
And so it's activists to do it on their behalf. So they don't have agency. I'm not sure I understand your point.
That was just a comparison.
With?
On whether they appeared actually in person will determine a lot on the awareness as people living with HIV/AIDS.
Nefak, did you have a protest last week?
We know them. We know me. They were.
Yes.
Okay.
So it's now the people living with HIV/AIDS ready to come.
All right. We'll come to it. Yes, I just want to get the gentleman's point. Clarity.
That was just a comment in the passing.
Yeah.
Actually, I don't want to make comments right now further now that we have experts, but I had a question, actually two. One is that as per the report, there is 97% of the people are aware of their HIV status. So my question is, where are the 3% of the people in the society? And also the other time, the president talked about the Linda Mama and the SHA and which one is doing better than the other. Are we, as now the experts in this particular field, is the government doing enough in preventing the mother-to-child transmission?
All right.
And lastly, I was going through the HIV/AIDS Act and the SHA and comparing the two. And I found that there is a fund established under the SHARE, that is the Social Health Insurance Fund, to cater for critical diseases, one of them being HIV/AIDS. So the experts can tell us whether they are utilizing that funds and whether the government is veiling the same.
Okay.
Thank you.
Yes, the lady next to you, and then I'll have the experts respond. There's quite a lot of comments.
Good evening. My name is Dorcas Chipto. I'm a student in JQuat, majoring in clinical medicine and surgery. My comment on the issue of is Kenya on track handling people living with HIV and AIDS? And I wanted to make a comment on doctors going on strike like we've seen earlier on the screen. These actually affect patients, especially mothers with HIV and AIDS, people living HIV and AIDS, because they won't be compliant with the medications. And when a patient is not compliant with medications, their viral load increases, which makes the infection even much worse. And we fail to make a progress on subsidizing the viral load among the people living with HIV and AIDS.
All right.
Yeah.
Okay. All right, thanks. Let's give the mic to the front and let's have just quick responses. Let's start with you, Dr. Busi. Just quick responses, one to all the questions, and then the next.
Thank you very much, James. I'll try and tackle a couple, and then Mula will also chime in. I'm very proud of this program. This is testimony of what we should be doing, because the young people have spoken, and they have given us a lot of answers. They have given us a lot of solutions. I think what we need to do is to engage the young people more. You can see it's not that they don't want to act. It's that they want information and support to make those decisions that are critical, so that they also stop the perpetuation of this epidemic that has been with us for far too long. I also want just to take this opportunity to honor the Kenyans who came out, who have enabled us to reduce stigma to the levels that people can talk about it today. People like the late Joe Mujioki, people who are now formed a network of elderly living with HIV. One of these fine days, you should also invite them to this show, so that you can have people who have lived with the virus for the last 30 years, for the last 35 years, and they share their story, so that the young people can listen and associate figures, numbers with faces. The 3% that Odinga talked about, the ones who are not, we currently don't know about where about 40,000 Kenyans who are living with the virus are. Most of them, they are men like me. Last year, out of all the HIV tests that were done in population 10 plus years, only 27% were among boys and men. Only 27% of the tests. The 73% were girls and women. So how will the boys and men ever come into care? How will they know? You don't know whether you are living with the virus by looking at me, how ugly or how beautiful I am. You know by getting tested. There is the issue of Nelson. And I want to add, on top of the lawyer that Odinga talked about, I want to add the parent. We are here. Our children are in schools. Our children are somewhere out, for those of us who have children. It is back to the basics at this moment in time. They change the transition between childhood and adulthood is called adolescence, and that's where children form their beliefs, morals, and values. If we could take that opportunity to ensure that the children are brought up right and taught the right values, so they do not get confused by the characters that my friend, I think it was Majera, was talking about what happens in those spaces. Those are suspicions. I don't know whether these people really do that, but if you have the right values and you are able to do the right thing, you're able to make the ethical decision of whether it is right or wrong, then our children will be safe. Lastly, it's a time that we cannot think about foreign donor assistance as a way to sustain this response. The Americans have told us it is America first. And that is the reason why some of those civil society organizations that were funded are no longer active, CIMAT, in the villages, in the communities that they operate in, because they no longer have those funds from the Presidential Emergency Plan for AIDS Relief. Right. It has been cut, especially for prevention. So we have to look inward, find sustainable solutions. Any funding that we get currently will be linked to transition from a donor-funded response to a country-owned mechanism. And that is why the agenda of His Excellency, the President, of universal health coverage, an integration of the essential package for health for HIV care and treatment within that social health insurance schemes, whichever they may be, is extremely important, so that we can stop the dependency on overseas donor assistance.
All right.
Thank you very much.
Thank you.
And over to Mulo.
Yes. Let's have some quick responses from
Thank you.
Tamulo.
Again, I must appreciate again NTV for this opportunity. I think every time we meet young people in the space of HIV programming, I keep saying I want to meet the real young people between the ages of 14 and 24, and I feel this room has that age set. So I'm very proud of the group that we have today. I will classify my response into two. One, the biological HIV. We know the virus, we know how it behaves, we know how it's transmitted. We have made a lot of scientific progress on that. Developing ARVs, we have moved from the pill burden, where patients would take, I mean, those who are older, no HIV patients would take tons and tons of drugs every day. That they had to set alarms to know what time to be set and all that. We have moved from there because we have made some scientific breakthroughs and we have molecules that are safer, that are more tolerated, and that can confer viral suppression. We have moved from TLD, and Kenya is a lead country in terms of safety and introduction of new molecules. I think right now we have already adopted the WHO guidelines for new ARVs, safer ARVs for older people and people who have kidney disease, and we have already rolled out as a country. And the guidelines were launched in June this year, and we have already, as a country, moved forward. We also have moved on about testing. We know how to testing. We have reached out people. I think we have said close to 98%, not close, 98% of people already know the HIV status. The 2% is a last mile approach, which Dr. Bosire has mentioned about. We also have new prevention methods. Long in the days, we used to talk about ABC, because condom was the only known prevention method. Abstain, be faithful, and condomize. That was what we used to say when we were growing up. We have moved. We now have novel products, the Piravin rings. We have oral PrEP. We have oral PEP for those who get exposed. And we have now the new lenacapavir, which Kenya is going to be one of the lead countries in rolling out. By January 2026, we will have the first patient in this republic get an injection for 6-month prevention of new infections. This will come in handy for the key populations that we are talking about, which is a real shot to actually ending new HIV infections. For the young people, the global community has already negotiated the global access price for this lenacapavir, moving down from, if you want lenacapavir in the US today, for a year, two shots is $28,000, which is about 35 million Kenya shillings if you want that today. Next year, in this country, you will be able to access free from the program for the population that we target, but because we want a whole market approach, we will also be able to access at 6,000 shillings, under 6,000, which is $40 for the 2 shots, which is 700 times decrease from the access from the manufacturer price that we are being, and that's a lot of progress. Something that everyone should be proud of, that we now have a real shot, because what this means is if you are HIV negative and you are likely to get exposed by either exposure, behavior, and you get the shot, you are guaranteed that you will not get new infection within a period of 6 months. Then I'll talk about the behavioral issues about HIV, which is what we have discussed here, the stigma. And I talked about, and I love the people living with HIV/AIDS. They have been able to come out. The U2U program that we are doing with the people living with HIV/AIDS, it is scientifically proven that if you are virally suppressed and your virus is undetectable, you cannot transmit HIV. And that actually has been our running mantra in ending stigma amongst people living with HIV. The issue of differentiated care, which has been talked about, HIV treatment optimization, where we have moved from where ARVs would only be available in clinics, which we used to call CCCs. Now ARVs are available through the community health program which we call community dispensation. We now give multi-month dispensation. Where a patient is stable and virally suppressed, they don't have to come to the hospital every month. We give them drugs for 6 months. They only visit the facility for 2 years. We have even moved further. Now we have made the ARVs available in your nearest pharmacy. You don't need to go to anyone's health facility. You just need to go to your nearest registered pharmacy. You pick your ARVs and go home. And only come to the facility when you need to do testing for monitoring. This is progress. And I think if we sustain that, we have a real shot of ending HIV as a disease of public health importance by 2030, which is the global target. Here in Kenya, led by our President and the Cabinet Secretary for Health, we have committed to ending new HIV infections in children by 2027, which is 2 years away. As a country, we have to do RRIs, we have to have conversations, we have to engage so that every mother who visits a facility for ANC gets HIV service. And we also need to understand the mothers. When we give them, we come. You have come for clinic. First, you did not know that you are expectant. You are coming to see the doctor for a different thing. You are told you are expectant. In the same sitting, you are told you are HIV positive. And they tell you, take these ARVs for the rest of your life. That is, we must be deliberate to follow this every mother who is diagnosed as HIV and follow them through the pregnancy to ensure, even if we have to do directly observed therapy, just like we do for TB, to ensure that they adhere to the treatment so that we prevent new infection. We must change, because one of the things that elimination of mother-to-child transmission has not changed is because we burden this mother. Sometimes some of them do not even know the father of the kid that they are carrying. You have told them they are pregnant. You have now told them they are HIV. You have now told them they have to take this medication. They will not take, because they are human beings. They will take erratically, and that's how. So we have to be deliberate, and we have to have this conversation as a society, not us as professionals, but as a society, and get a mechanism that addresses the real issues as they are. Thank you very much.
All right. Latif, we can keep on here.
We can go on and on, but I think, Dr. You've summarized it very well, and Dr. Busira the same. The question that we are asking ourselves tonight is whether Kenya is on track in the fight against HIV. And I think just looking at that, looking at the level of awareness, and we've talked about the level of awareness being high, the program 95, and the successes of it, over 97% of those who have tested positive for HIV are on treatment, over 94% viral suppression. Those are indicators that we are on track and that we are actually making some good progress. The fact that we are having such conversations in the community without people hiding is also something we can say that it's some level of progress that we've made. However, concerns have emerged from data, from what we've seen from the Syndromic Disease Control Council. There's concerns about new infections and the age of new infections and the rise in that age group. There are also concerns that you've told us about today about people who are not continuing the treatment. So they start, they get onto antiretroviral treatment, and they stop. Concerns on mother-to-child transmission, those ones are as well high. So all these concerns are contributing to what we are seeing now as the changes. So as much as we are making progress, we've got to realize that these concerns are valid. And we've got to come with deliberate measures and efforts to address these concerns. Like Dr. Mulo has said, we have to stop doing things the way we've been doing, and we've got to be deliberate in doing things a bit different to address this communication. Communication among this young population go to where they are, in the platforms where they are, in the spaces where they are, in the language that they understand and relate with. If it's about sensitization campaigns at community level, we've got to do it better. Not coming there with dust coats and all, but finding new ways of communicating in the communities, because we are dealing with a younger population, and this is a younger population that's exposed to HIV. So, the last word tonight, yes, Kenya is making progress. There's reason for us to take stock of that, but there's also reason for us not to rest on our laurels, but to accept that there are rising, emerging concerns, and we have to address these concerns head on. And that is the last word. My name is Eric Latif. On behalf of Sharon Momanyi, James Mart, and Zaha Indimuli, and our audience tonight, including our doctors, Dr. Douglas Busire, the acting head of the National Syndemic Disease Control Council, and Dr. Andrew Mulo, who's the head of the National AIDS and STI Control Program, and our audience from the community. Asanteni sana for this tonight, and have a good night. You had an opportunity to say